Good evening, and thank Dr. Pirama and the organizers for giving us this opportunity to chair this very important session on preventive gastroenterology, orchestrated by Dr. Seshadri. Thank you very much. If you looked at gastroenterology and what the advances are, it's all in endoscopy. People want to do EUS, people want to do cannulation, difficult cannulation, and so on and so forth. But rarely do we have a session where prevention of these diseases could perhaps be more helpful. And for this, we have a very exciting three-member panel who are going to give us 3 lectures of 30 minutes each. The first speaker is Dr. Paraniyappan. Dr. Paraniyappan Manikam. May I request you to come to the stage, please? He is from Sacramento. He has got an excellent career. He did his undergraduation in PSG Institute. He has got masters in public health. He is a resident physician in Michigan. He's a clinical assistant professor, fellow of the gastroenterology and hepatology. He's got a wide variety of publications. He's a teacher, and today we are honored by his presence. And he's going to talk to us on preventive gastroenterology, the gut feeling. We will have a lot of questions at the end of the session, sir. Over to you.
Thank you so much. And thank you so much for the opportunity to present over here. Let me see whether I can get this going. Okay, super. Very good evening. Let me just get the lay of the land over here. How many PGs over here? Okay. Evening, sir. Your postcard. All of us. So this talk is mainly for the PGs. For the first half. The second half is for not only gastroenterologist, for any doctor who is going to pursue MBBS in this decade. So this is what it's going to be like a combination of my personal story and also in terms of how my career changed from full-blown inpatient gastroenterology. Okay, so I'll try to finish this within half an hour. Okay, so as I said, it's my story. So this is my journey. Okay, so I'm a 2000 batch graduate, MBBS in PhD Coimbatore. I was very focused on USMLE because I wanted to get state-of-the-art training. So in 2006, nobody in my batch applied for USMLE. It's only me. So I really found it very hard to figure out the way, and finally I figured out the way that we have to go and do another master's course called Masters in Public Health, and then we have to apply for MD General Medicine through that. So I did that. It was a long journey, but finally I got success. I was successful, and then I did my MD General Medicine, and then I did my gastroenterology fellowship for 3 years, and then I did an advanced fellowship on EUS and ERCP for a year. So I was practicing as a full-time gastroenterologist in 2015 with expertise in hepatobiliary pancreatic stuff. Okay, so my bread and butter was EUS and FNA for pancreatic head mass lesion, and then combined with ERCP with a stent placement was my bread and butter. Okay, so this is my story. From 2000 to 2015, I did all this, and then similar to all this beautiful and handsome PGs over here, I was really focused on my career, and then I got really big. I was 100 kilos. So, and then I got married and we were in the US. It was in California. Okay, so at the age of 33, I had a small heart attack while doing a procedure in ERCP. Okay, so it was an obstructive jaundice case. I still remember that. I had a chest pain and palpitations, and then we was admitted in the hospital. And I was thinking in the hospital, like, what went wrong? Like, I abused my body despite being a medical professional, right? So I didn't know what I was doing. I was only focused on career. I didn't know about diet. I didn't know about exercise. I didn't know about work-life balance at all. Coming from a lower middle class family, I was just focused on how do I settle my finances? How do I settle my career? I just completely abused my body, and the body was a window for me to reflect about what I was doing. Okay, so this was my wake-up call, and the presentation is about I changed, and I'm pretty sure that what I did is the state of the art over here in India, at least. I don't think the system has changed. I don't think the career has changed much. You have to put in the hard work. I'm here to tell you that you don't have to put in the hard work in a way that you need to. You can put it in a smart way as well, where you can combine your work-life balance together. Okay, so after going through multiple dietary interventions, you name it. Okay, any PGs, any diet that you would recommend for your patient for weight loss? ஒன்றும் சொல்ல மாட்டீங்களா? என்ன வேணாலும் சாப்பிடணும்னு சொல்லுவீங்களா? என்ன சொல்லுவீங்க உங்கள் டயட் வெயிட் லாஸ்? ஃபேட்டி லிவர்னு வரான் டயட், என்ன சொல்லுவீங்க? டயட் அண்ட் எக்ஸசைஸ். என்ன டயட் சார் சாப்பிடணும் அப்படின்னு சொல்லி என்ன சொல்லுவீங்க? கம்மியாக சாப்பிடணும்னு சொல்லுவாங்க. நீங்கள் போய் ஆர்ஆர் பிரியாணியில் வாங்கியிருக்கீங்களா? பிரியாணி கம்மியாக கொடுக்கவே மாட்டேங்கிறாங்க. ஓகே, ஸோ வாட் ஹெல்ப் மீ வாஸ் ஐ மேட் மல்டிபிள் அட்டம்ப்ஸ் அட் டிஃப்ரெண்ட் டயட்ஸ். ஓகே, ஐ டென்ட் ஈவன் நோ யூ நேம் இட். Paleo diet, keto diet, polio diet, you remember, you name it. Okay, every diet I tried. Okay, so then we realized that I got involved with Dr. Sachin Panda. Sachin Panda, if you don't know, I mean, including the faculty over here, please Google him. He's such a wonderful researcher on circadian rhythm. It's our Sachin Tendulkarla T varum nadula. Sachin, SATCHIN, Sachin Panda, PANDA. So he has published so much on circadian rhythm, and I partnered with him for a clinical research. He used to do basic science research, and I used to do clinical research with him in my fatty liver patients in California. Okay, so what we figured out was there was a gut liver axis, gut brain axis, gut skin axis. There is also something called gut bone axis as well. And more importantly, there is a gut HPA axis, hypothalamic pituitary axis. Okay, there's a strong connection between these two. And when HPA is bothered, that is where the problem starts. It can be PCOS with your non-communicable diseases in women, and diabetes, obesity, hypercholesterolemia, fatty liver, which is a part and parcel of our gastroenterology. Everything is boiling down at the molecular level of your gut. Okay, gastrointestinal GIPGs. When I say gut bacteria, where is the gut bacteria located at? In the gastrointestinal tract. Colon. Yes, colon. Any number? How much amount of gut bacteria that we have? Any number? Just guess. Nobody knows the answer. Just guess. 100 trillion. Good. You follow my channel? Good. 100 trillion வந்து எவ்வளவு zeros இருக்கு? 1 followed by 14, sir. Super, sir. Very nice. 1 followed by 14. 14 zeros. If you have to explain that to an Indian patient in Tamil, how many crores are there? It's 1 crore. 1 crore bacteria. Okay? இப்போ நீங்கள் தமிழில் பேசணும் அப்படின்னா 1 கோடி நுண்ணுயிர்கள் பெருங்குடலில் இருக்கு. Okay, so you need to understand that. So what we figured out was, no matter, we have made sure that research also confirms that your gut is your foundation for any kind of non-communicable diseases, right? So how do we improve this gut? Right? So these are the 6 pillars that we thought it's going to be helpful for any patient that you see, especially for SIBO patients. You know SIBO? Small intestinal bacterial overgrowth patients, your IBD patients, your fatty liver patients. A gastroenterological consultation should not be completed without evaluating the 6 pillars. If you are doing it, it is unethical to the patient. We are not here to be just a band-aid. We are a physician. We need to heal the patient as a whole. Okay, so the first thing I want you to focus is on circadian rhythm. Okay, so what we figured out was, we did 2 groups of mice, and then we said, okay, we're going to give isocalorie diet in group A, where we feed from 7 a.m. to 7 p.m. The same isocalorie diet we gave from 7 p.m. to 7 a.m. on group B mice as well. Okay, so we followed for 3 months. Which group you think that they lost weight? 7 a.m. to 7 p.m., right? Nobody lost weight. Nobody lost weight. But when you look into the group A in 7 a.m. to 7 p.m., the glucose levels, the cholesterol levels, the A1C levels, everything came down. And when you keep doing that for another 3 months, in 6 months, we noted 3% of weight loss. This is an extremely, extremely important finding. It's very, very important finding that if you align with your circadian rhythm, the hormonal quality, especially your digestive hormone, which is your insulin, the quality is much, much higher. So when you talk to your patient who's not willing to give that biryani out, what you should say is, it is okay to include biryani. அப்பதான் ஒருத்தர் கரெக்டாக சாப்பிட்றாரு, பரவாயில்ல சாப்பிடுங்க நீங்கள், நோ ப்ராப்ளம், ஓகே, ஒன்றும் பிரச்சனை இல்லை. Okay, so you have to make sure that it is okay to eat the biryani, okay, but it needs to be within a limited time. Okay, limited time. So this is something that I want everybody to follow. So the reason is, every hormone, every cell in our body has a circadian rhythm. It sleeps at a certain time and it wakes up at a certain time. Gastrointestinal PGs, GI PGs, including DIPN-B and MD, DM. Tell me when insulin is secreted and peaked. When is in a 24-hour cycle, when is an insulin hormone is at its peak? உடனே சாருக்கு ஃபோன் வந்துருச்சு. Anybody, just guess. PGs. You don't have to be right. Only if you answer, then it will get stuck in your mind. So don't think that I'm roasting you. Okay, this is a way for you to remember. Morning, afternoon, evening, 1 to 2 hours after meal. No. So that is the misinformation that I want to clarify. When we think insulin, we only feel like only it will increase after meal, right? But there is a natural circadian rhythm to it. Let's say you don't eat at all. Insulin will be secreted or not? It will still be secreted, right? But not in that much amount. So what is the natural circadian rhythm? Where is the insulin peak? Morning, afternoon, evening. I gave you only 3 options. Morning, கிடையாது. Okay, afternoon, evening. இன்னும் ஒரே ஒரு ஆப்ஷன் தான் இருக்கு, afternoon. மறக்க மாட்டீங்களா இனிமே? Okay, so insulin peaks at 2 p.m. Okay, it secretes at 7 a.m., 8 a.m. in the morning. What stimulates insulin secretion? Any idea? சும்மா சொல்லுங்க. You just throw answers at me. Only then you will remember, I'm telling you. What stimulates? Waking up will stimulate insulin secretion. Drinking coffee will stimulate insulin secretion. Going to the bathroom will stimulate insulin. Which is the most powerful stimulator of insulin secretion in the morning? Waking up? Okay, good. Waking up. Anybody else? What is the one external factor that will stimulate the insulin through the eyes? Light. Which light? Tube light. Sunlight, right? Why? What is there in the eye? It is photoreceptors are in the retina, right? And what are the? Have you heard about that pigments cells? What are the 2 types of cells? Good, very nice, beautiful. Rods and cones. Rods and cones, when you stimulate it, it is directly connected to your suprachiasmatic nucleus. That is where you secrete that is where the stimulation of HPA axis happens. And that is where your insulin gets secreted. Okay? So how much amount of sunlight that you need? You have to go outside to see the sun altogether, or you just need to see 1 ray of sunlight? What's the answer? 1 ray of sunlight is good enough. Sun is extremely powerful, especially in Tamil Nadu. ஜோக்கு புரியலன்னா வீட்டில் போய் பாருங்க. ஓகே, ஐயோ. Okay, so anyway, so sun is extremely powerful. Okay, so one ray of sunlight is good enough to okay, so that is why for all your patients, you should say that eat at 7 p.m., sleep at 10 p.m., wake up at 6 a.m. சும்மா சொல்லுங்க, பண்ண மாட்டாங்க எப்படி இருந்தாலும். Okay, so this is something that is very, very important, especially for restructuring your gut health, especially if you're sick. How many of you are actually doing this? How many of you are eating at 7 p.m. PGs? I'm not going to ask the faculty. Super, sir. PGs, faculty, CPGs, anybody else who's eating at 7 p.m. in addition to sir? Super, sir. Very nice. See, all experienced people are raising the hands. Right? All the young people are like only at 11 p.m., sir. Okay, so minimum 12 hours fasting is absolutely needed. Age more than 12 until there is no limit to this. If you are on insulin, if you are on diabetes, doesn't matter. Age more than 12 hours of minimal fasting is absolutely important. Okay, when you are advising this to your women patients, please be careful that around the perimenstrual period there is an increased cravings because of progesterone, so you may have to adjust the window a little bit. Okay, so the other thing that we figured out was, if you don't stimulate your insulin secretion repeatedly, your insulin quality is very, very high. So you don't have to snack in between. What is the most common snack here in Tamil Nadu for your patients? என்ன சாப்பிடுவாங்க ஸ்நாக்கா? Bajji. Correct, exactly, sir. Bajji. What will you say? He says, I cannot leave the bajji. Bajji நீங்கள் என்னை எடுத்தீங்க டென்ஷன் ஆயிடுவேன் அப்படி யாராவது சொன்னால் என்ன சொல்லுவீங்க பேஷண்ட்ஸ்ல? You can have your bajji along with your dinner. That is the key. Or along with your lunch. You should not, there is the concept of 3 meals a day, small and frequent meals, is only for certain group of patients, but not for everybody. Majority, we don't need 3 meals a day. We have more calories that is needed. So avoid snacking. The second thing is full sleep. Okay, as a medical professional, how many of us are sleeping more than 7 hours a day? No? Anybody? More than 7 hours a day? நீங்களா சார்? ரிட்டையர்டா சார் நீங்கள்? அதான் சார் தூக்குறீங்க. அதான் சார். So all junior gastroenterologists and also the trainee, this is something that you need to really prioritize, guys. There is no other option at all. Okay, there is no point in waking up at 5 a.m. sleeping at 12 a.m. It is going to catch up with you. Learn from me. Don't repeat the same mistake I did. Prioritize your sleep. Those 2 hours, if it is something that you can do later in the day, it is absolutely important to do. This is what you need to tell your patients as well. If your brain-gut axis is not strong, there is no point in giving dicyclomin. There is no point in giving psyllium husk. There is no point in giving mesalamine. The outcome will not be there. The outcome will be blunted. Okay, it will be there, but if all this is fixed, it will be even higher. So 5.5 hours of sleep can actually cause significant amount of fat mass, and for Indian people it gets deposited in your belly because we are genetically predisposed. There is something called thin fat baby hypothesis. Please review that. We don't have time to go through that right now. Okay, again another NCDs tied down to sleep. Insufficient sleep, again short sleep, less than 5 hours, is invariably tied down to type 2 diabetes mellitus. Why is this happening? If you think about it, when you have enough sleep, which hormone is getting secreted in sleep? Growth hormone. Who's the growth hormone? Yes, super. What's your name? Beautiful. Super. Very nice. Good job, Kiran. Very nice. Kiran. Growth hormone. Exactly. Growth hormone is the one that will repair the damage that you're doing. நீங்கள் என்ன சாப்பிட்டீங்க இப்போ? கிரண், what did you eat now? சிக்கன். இல்லை பரவாயில்ல, தப்பு கிடையாது. மெதுவாக சொல்கிறேன் கிரண், சிக்கன் இன்னைக்கு மட்டும் தான் சாப்பிட்டேன் சார். பரவாயில்ல, தப்பு கிடையாது. ஓகே, when you eat chicken, it goes into your esophagus, it goes into your stomach. What cells is stimulated in the antrum to secrete the acid? மறந்துட்டேனே, பரவாயில்ல, இன்னும் சிக்கன் சாப்பிட்றேன் அப்படின்னா. What cells? Parietal, G cells, right? So G cells secretes the acid, right? How does it secrete the acid? Through the luminal exchange, right? Exactly. H plus K plus ATPase, right? Luminal exchange. Every time a cell is being opened, the exchange happens, acid is secreted, your chicken is digested, pancreatic amylase comes in, right? It's all digestive. It's like a beautiful synchrony, right? But the open cell needs to close back, right? When does it close back? During sleep. That is where your growth hormone comes and repair all the damage. If you look at it, there is a study in breast cancer patients where breast cancer patients are prioritized for sleep for 7 hours and fasting for 16 hours, and the symptom improvement is much better. And the reason for that is when you are not repairing properly, that is the nidus for development of precancerous cells. Okay, so in my practice, I always include this: almonds, spinach, and dark chocolate. Whenever patient has a gut cravings, you have sweet cravings, you will have to tell them you need to trick your gut bacteria. So the trick that you should do is dark chocolate 70% and more, or almonds with dark chocolate cover. As you know, tryptophan is converted into serotonin, and serotonin will promote sleep, and that is why we recommend daily full glass of milk is completely okay, but not before going to bed. You need to have how many hours of rest between the last dinner and the 3 hours. Correct. Super. Chronic stress is a hidden factor that is also disrupting your gut health. Okay. On a scale of 1 to 10, all the PGs, how stressed are you, with 10 being very high? உடனே உங்க ப்ரொஃபஸரை பார்க்குறாங்க, -1 அப்படிங்கிற அந்த பையன். I will tell you, when I was a PG, my stress was 11 out of 10. Okay, but that is why I ended up in the hospital bed. I don't want you to do the same thing. Okay, so you will have to increase your bandwidth to handle stress. Does this mean that you're going to avoid gastroenterology rotations and then just go to a movie? No. You will still do what you want. You do your passion, but you will have to increase your bandwidth. Take a picture of all the PGs. Take a picture of the slide. And I want you to do at least one of this from tomorrow on a daily basis. Okay. Look at that. In the center of the picture is minimize digital overload, and we are taking a picture with the phone. Okay, so that is how connected we are with social media. So we really need to make sure that at least something. One thing that I always do with my patients, every time a patient walks into my office, I make them do this boxed breathing technique. It's a very simple technique. Inhale 1, 2, 3, 4, hold for 1, 2, 3, 4, and exhale for 1, 2, 3, 4. This is something is going to help you personally as well. The next time when you don't know what to do, when your professor is asking a question, what is the risk factors for Crohn's disease? Tell the professor that wait for 4 seconds, let me do the boxed breathing. Okay, it will lower your cortisol level. Okay. Fourth is smart nutrition. Just remember, being a gastroenterologist, we all know that nutrition plays a role. அது பரவாயில்லப்பா, டீப் ஃப்ரைட் சிக்கன் விட்டுருங்கப்பா, திருப்பி நீங்கள் அவங்ககிட்டே வரீங்க. நீ கிரண் சொல்றான், அப்பா என்னைய விட்டுரு, நான் இனிமே சாப்பிட மாட்டேன். இதான் ஸ்நாக்கா? ஐயோ, ஸ்நாக்கே ஃபுல் மீல் மாதிரி இருக்கு. Okay, so major thing I want to focus on is that if you really paid attention to the presentation, there were 6 pillars. Despite being a gastroenterologist, I did not put nutrition as the first pillar. If you don't have the foundation with the other 3, gut, rest, sleep, and stress management, there is no point in talking about diet. Okay, you will put so much effort into the diet, the patient will not be able to see the results because all the 3 factors are not there. So diet, one of the most important thing as a gastroenterologist you need to focus is only on fiber. There is nothing else. Kiran, I don't know, the Kiran name is very popular, so I'm going to ask you, do you ask your patients how much fiber you take every day? No. எப்படி கேட்க முடியும்? அப்பா 1000 பேஷண்ட் நிற்கிறாங்கல்ல, எல்லாருக்கிட்டையும் எப்படி ஃபைபர் வந்து கேட்க முடியும்? There is no way, right? There should be a patient education part where you should understand that minimum number of fiber is depending upon the physical activity level. Okay, so Kiran, are you physically active? Duty on and off? எப்போ ஆனா இருப்ப, எப்போ ஆஃபா இருப்ப? When there is no clustering of duties. நீ அப்போலோ தானே? அப்போலோவில் எப்படிடா ஆஃபாக இருக்க முடியும்? ஆன் தானே எப்பவுமே. ஓ, யுவர் செகண்ட் இயரா? ஓகே, சூப்பர். Out of this thing, what do you think? You are moderately active or you are very active? உட்காரு, நீ உட்காந்து நினைச்சாலே moderately active ஆயிப்போலையா? Very active. What do you do for very active? 15 to 20,000 steps per day. அப்போலோலையா? எப்படி? You just go up and down? You don't use lift. Super, very nice. Good job, Dakaran. Wonderful, wonderful. Sit down. Beautiful. So you are the quicker way. Is the reason I'm saying all this is it's a very important tool to practice on your patients is that you have a body weight, right? This is in pounds. You just have to multiply by 2. Let's say 100 kilos or 70 kilos into 2.2 would be like 160. So 160, 1600 calories would be your active, right? So you just need to tell this number to your patient. And unfortunately, gastroenterologists don't have time to just go deep into it, but you will have to train your team in terms of calorie plus fiber is very, very important. Okay. Protein is important, but more than that, as a gastroenterologist, we need to promote protein or fiber. For protein, the number that you should remember is 1 gram per kilogram per day. You guys had paneer now? 2 slices? 20, yeah? 2, எவ்வளோ ஸ்லைஸ்பா? 6 7 போட்டு கொடுக்குறான். அந்த ஒரு ஸ்லைஸ் ஆஃப் பன்னீர்ல எவ்வளோ ப்ரோட்டீன் இருக்குன்னு நினைக்கிறீங்க? எனி நம்பர்? ஓ, ஐம் ரன்னிங் அவுட் ஆஃப் டைம். Yeah, every 100 grams of protein is 15 grams of, every 100 grams of paneer is 15 grams of protein. Okay. So as a medical professional, we have to start noticing what we eat so we can tell the patients in terms of how you achieve 1 gram per kilogram per day. The reason that you need to achieve 1 gram per kilogram is per day is research shows that that is the minimal requirement for the brain gut axis to work. If it doesn't work, there is delayed migratory motor complex transition. Do you know what MMC is? Madras Medical College kadiyadu. Migratory motor complex. Okay. All right. So out of these 3, PPP, which P is most important for Indian community? Portion is extremely critical. Okay. Out of these 4 things, nutrient rich, fiber rich, high in protein, enjoyable, which of the 4 things is going to be very important for your patient? 4th thing, enjoyable. No matter what kind of thing that you do, it needs to be enjoyable. If not, it will not sustain. The last one is hydration. How much amount of water people should do every day? How much amount of water should patient to drink? 2 liters per day? 3 liters per day? Minimum 2 liters. More than. How do you know? Patient is going to ask, how do I know that I drink 2 liters of water per day? Urine color is one thing. Also, I asked a patient from India, I asked, how do you know you are 2 liters? He said, 750, 200, sir. So the last one is exercise. Okay. Exercise, we did a research in Stanford. Okay. What we figured out was, regardless of the diet, no matter how much amount of ultra processed food that you take, exercise itself can promote short chain fatty acids of your acetate and butyrate and propionate in the large intestine directly. Okay, independent on the dietary intake. This is something very, very important for you to do. Okay, so this is extremely important if you have a patient with IBS, if you have a patient with SIBO, if you have a patient with IBD, if you have a patient with fatty liver. This should be your top priority. Okay, exercise is something that a patient should not leave without a prescription with. Okay, so more importantly, don't focus on 10,000 steps per day. Consistency. Even if a patient can do 5,000 steps per day, it needs to be consistent on a daily basis. Always consistent is more than volume. What is NEAT? Anybody know what is NEAT? Not the entrance exam. Non-exercise activity. Super. Very nice. What's your name? Huh? Ajay. Beautiful. Good job, Ajay. Very nice. Very nice. Very nice. Ajay. Very nice. Non-exercise activity thermogenesis. What it means is, do you guys have 1 hour on your day to do exercise? There is no way, right? You guys are trainees, right? You have to work harder. How do you trick the system is every 1 hour in your OP, when you're sitting up to 55 minutes, the remaining 5 minutes, you just walk your stairs up and down 2 times. That is called NEAT. It is non-exercise activity thermogenesis with a little bit of an activity here and there. For example, let's say this is a clicker, right? If you keep on doing like this is non-exercise induced. What is it? Okay, and also, like flickering, fidgeting, all this is a non-exercise activity thermogenesis. But something that is very important is you will have to stimulate that exercise axis. If not, that's not going to work. Second thing is you have to advise your patients to walk 10 minutes after meal. every meal patient should definitely walk for 10 minutes minimum. There is no other option, especially when they have insulin resistance. Okay, insulin resistance. Okay, so cardio, strength, flexibility, walking, all this matters, but the most important thing is exercise snacking. Okay, similar to how we eat bhaji in between lunch and dinner, you will not have to think exercise as a complete 1 hour thing. You can do this as a exercise snacking, like 5 minutes in between snacking. Like, as I said, take the stairs twice is my favorite exercise snacks. I tell my patients that in an office you do this, people will think that you are very busy. Okay, so this is what a patient needs. Okay, based on my experience, I just take 5 more minutes of your time. Uh, my I have been in an inpatient gastroenterology with active, very busy schedule with controlling variceal bleeds, putting stent in cholangitis patients, your steroid refractory ulcerative colitis patients. We have started them on infliximab. I have had palliative care discussions with your hepatocellular carcinoma patients. I have seen everything. Okay, I have done 10 years of gastroenterology practice, very, very busy, very, very busy practice. Now, I have figured out that right now what we are doing is a band aid. It is not addressing the root cause. If you are very happy that you are putting a stent in a heart attack patient and put a big flyer in the airport that my hospital is the #1 hospital, that is not how a medical system should work. It should work in a way that how you prevent that patient from having another heart attack. Then we will really praise you, right? So in my experience, especially for gastroenterology, this is what a patient needs: a detailed doctor evaluation. Given the infrastructure here in India, there is no way that you're going to spend 45 minutes with a patient. It needs to be, you guys are spending 5-10 minutes with a patient. That is because of the patient volume, right? You will have to create a system in a way that a detailed doctor evaluation of the lifestyle factors needs to be included. Second, the patient should be assigned a qualified life coach. What we mean by life coach in the US is they will be monitoring the patient on a daily basis, creating neuroplasticity. How many of you heard of this term neuroplasticity? Raise your hands. Super. What does neuroplasticity mean? Habits. You create habit. How do you create a habit? You build new neurons in the brain. How do you build new neurons in the brain? By repetition. By repetition. That's the only way that you can do this. There is a connection between your limbic system and your prefrontal cortex. What is that called? It's called ACC. Any guesses? Anterior cingulate cortex. Beautiful, beautiful. Kiran, super ra. You can have one more chicken ra. Very nice, super. ACC. Okay, ACC. All your patients are listening to the limbic system. That don't do exercise, it is very difficult. Don't do diet, it is very difficult. You will have to create that new neurons connecting from the limbic system to prefrontal cortex. So prefrontal cortex is your decision making. For that you need repetition. You need to have a life coach or a nurse or even a doctor himself need to talk to the patient on a daily basis. And being a gastroenterologist, we should not be fooled by the term dietitian anymore. It is our duty to analyze whether that dietitian is trained in digestive disease dietitian. Okay, there is something called Monash University. How many of you have heard this term, Monash University? No. How many of you have heard FODMAP diet? Okay, why we do FODMAP diet for? IBS, right? Do you know what IBS? How do you guys do FODMAP diet? You guys give a handout to your patients and then say avoid this, correct? Do you think they're going to follow? No. Then how do they go into then they go to a dietitian. The dietitian will never know what a FODMAP diet is. Okay. There is a specialized advanced courses in the US. Digestive disease dietitian is a separate department. A dietitian working with diabetes or weight loss is not going to help our GI patients. You need to understand that. Unfortunately, in India, we have a significant dearth of dietitians who are specialized in digestive diseases. So it is getting better, but hopefully it will get better, even better. So you have a dedicated medical team of doctors supervising the patient. When I say that is, for example, when there's a sleep problem, you should have access to a sleep therapist within the system. For example, let's say you are an Apollo, Kiran is an Apollo, so there are sleep therapists. I know Dr. Ramakrishnan is there. You are a doctor, so you should have connection with the Dr. Ramakrishnan or anybody else within the system, so that you know what he is doing and he should know what you are doing. It should be a multidisciplinary approach. That is one good thing in a multi-specialty hospital where everything is ready, but the connections should happen. It cannot be on a separate basis. A behavioral therapist is something extremely important. What is CBT? What does cognitive behavioral therapy do? We don't know. CBT, only thing I think I can speak for all the medical doctors here. Only way that we know CBT is it is the right answer for the multiple choice question on the US Memory exam. Okay, we don't know what CBT does. CBT is the second rule that I said. You remember the qualified life coach talking to the patient of repetition, neuroplasticity, and create, that is called CBT. Okay, and the CBT also involves restructuring your thoughts. Your negative thoughts will be converted to positive thoughts. So you need a psychologist, not a psychiatrist. You need a psychologist. Remember that. All your IBS patients should be connected with a psychologist. Again, if you don't do that, it is not an ethical practice. There is a program called MBSR, Mindfulness Based Stress Reduction Program. It is an 8-week program available online. Either your institute should learn it and then teach it to the patients, or you can have the patients take the program online as well. And a physiotherapist for physical activity. Many of the women patients will have low back pain, neck pain, and they will not do physical activity. The more and more they don't do physical activity, they are damaging their muscles and bones even more every year. So that is very, very important, and the virtual gym access is absolutely needed. Okay, so this is exactly what happened with me. I got really burned out. I did EGD, colon. I said, no, nothing is wrong with you. You go and fix your lifestyle. The patient keeps coming back. I felt like I was a mechanic. I just kept on doing endoscopies. I was not treating the patient. I didn't get satisfied at all. I really felt burned out. I didn't get the reward that I joined medicine for. I felt like our medical system is rigged, that we are just being a treatment person. We are not focusing on the prevention part. Okay, so that's why I keep repeatedly saying that medical treatment is just a band-aid. Why do hospitals in the US don't practice this model? Because there is no money in it. There is money in endoscopy, there is money in EUS, ERCP, but there is no money in a doctor talking to a patient for an hour. Okay, there is insurance will not cover. Insurance companies, I called so many times, nothing happened. They will not cover my time at all. I will spend 1 hour, they will pay me only for 10 minutes. Okay, I was losing money while I was doing this. Okay, basically I did this. I'm not a saint to all this, right? I did this because something happened to me. Then I realized from a patient standpoint in terms of how a patient is being manipulated in the system. I lobbied hard with my hospital to get insurance coverage. It was not very easy at all. No insurance was ready to, but eventually we did. Okay, Dignity Health is my hospital. I work in California. We created a newer department called Preventive Gastroenterology. I strongly believe that every multi-specialty hospital over here should have this department. Every clinic, let's say PGs, you're graduating out and become a community gastroenterologist, you should have an access to all the things that I talked about within your hand reach. Okay, these are all some successful clients. So I said, what if I can do this locally in California? Can I do this virtually? So this is all I need, right? If I can put this together, then the patient needs everything is in a one-stop shop. So I said the hospitals were completely wrong. They said it's going to be expensive, $3,600 per month if you want all this. It is absolutely wrong. Everything can be done within $150 a month is the average price that is needed to create this kind of life-changing people results. Okay, so it is made, all these people came to us for SIBO IBS problems, but we treated them and reversed their diabetes and PCOS and everything. Okay, so the most important thing is if you build that neuroplasticity and if you create that new neurons in your brain, the weight that they lost, the A1C that they reversed, the PCOS that they were able to rectify will never ever come back, because those new neurons will do the job for the rest of their life. Okay, it's very, very important. I wish all hospitals and doctors in India adopt this model. This is my team. It's called New Me. It's a virtual program. We have close to 70 people. We have 40 life coaches. We have 4 to 5 doctors. We have virtual gym, we have physiotherapists, we have psychologists, we have sleep health specialists. We have one-stop shop for GI patients. We also have a same solution for NCDs as well. The success of the program depends on the quality of the life coaches that is there in the program. You cannot talk to your patients on a daily basis. You will have to create clones of you who will be able to provide good quality services. The fact that the statement I reversed your A1C because of your method will give you so much amount of satisfaction rather than controlling a variceal bleed in the middle of the night. I guarantee you this is something, a newer phase of medicine, not only in gastroenterology. Everybody should do this. It was not easy to put this team together. I did this because this is my mission, this is my passion, this is what I do on my social media as well. I want you to scan this QR code, especially the PGs. I want you to go through the resources that is there, and I want you to put it in your practice whenever you are practicing outside after the training. Okay, so may God bless all our patients, and let's change the medical system. Let's just not be just a band-aid. Let's make sure that we treat the root cause as well. Thank you.
So we deeply appreciate you, and
you,
probably we will take the questions at the end of the session if I'm right. And then before we move to the next session, I'll ask only one question to the audience. How many of you believe that diabetes is reversible? How many of you believe that diabetes is reversible? Okay, we will have the discussion a little later. Moving to the next topic, I have the pleasure in calling Dr. L. Sujata from Adayar Cancer Institute. Preventive strategies against GI cancers in daily practice.
Good evening, everyone. I would like to thank Paramanayagam sir and TNISG for this opportunity. My previous speaker, Dr. Palaniyappan, has covered extensively about preventive gastroenterology. Essentially, all the cancer prevention is built upon it, so which I will be doing now. What I am going to talk today, nothing is new. All those or we are practicing in our daily practice. The idea of giving this topic is not to chase any theoretical novelties, but to provide a renewed perspective on how to apply these strategies in our daily practice to build the crucial gaps in cancer prevention. Hope I'll do the justice. So since it is a vast and ambiguous topic, I'll be approaching it in a case-based discussion. My first patient is a 65 years old male who is a chronic smoker. He had a tongue ulcer which was initially managed conservatively. Later it turned out to be squamous cell carcinoma. He underwent definitive chemoradiation for the same. In our institute, we do surveillance endoscopy for all the newly diagnosed and follow patients of head and neck and esophageal cancer. Similarly, this patient this patient was diagnosed with early esophageal cancer 6 months later in cervical esophagus, for which he underwent endoscopic submucosal dissection. And we continued annual surveillance. 5 years later, he was diagnosed with another early esophageal lesion in the lower thoracic esophagus, for which he underwent second EST. And now he is 70 years old and he is on follow-up with us. The point to be taken here is all the patients with treated head and neck cancers and esophageal cancers should be kept under close surveillance so that we can pick up the lesions earlier and resect them endoscopically, which will be curative and improve the quality of their life. So the risk factors of head and neck cancer and esophageal cancers are well known: chronic smoking and alcohol consumption, human papilloma virus infection and Epstein-Barr infection to some extent, and present and past history of head and neck cancers, previous history of caustic ingestion, achalasia cardia, Plummer-Vinson syndrome, and certain familial conditions causes esophageal squamous cell carcinoma. Esophageal adenocarcinoma is more common among patients who are obese and having chronic GERD and Barrett's esophagus. We all know that tobacco is strongly linked with many cancers in the body. It can be either smoked tobaccos or smokeless tobaccos like chewing tobacco or snuffing, or active or passive smoking. All this are strongly linked with many cancers. Nowadays, the practice of vaping and e-cigarettes are increasing, especially among young adults and adolescents, thinking that it is harmless. This is a study from Center of Addiction and Mental Health, Project Vector. It clearly states, though there are no established human studies that e-cigarettes can cause cancer, still the people who smoke e-cigarettes are exposed to cancer-causing chemicals. So it should be avoided wherever possible. Human papilloma infection is well associated with cervical cancer since many decades. With evolving studies, the virus has extended its oncological footprint in many other cancers also, which includes anal canal cancer, oropharyngeal cancers, and colorectal cancers. Thus, human papilloma virus vaccine should be given for all the appropriate age people, that is preferably 9 to 25 years old, both male and female, which can decrease the risk of developing cervical cancer, genital warts, anal cancer, and to some extent oropharyngeal cancers also. So good endoscopy requires high definition magnifying white light endoscopy, and the mucosal visibility should be better. It should be clean of mucus and debris. We should be familiar with the normal pattern to pick up the irregularity, and freezing the images allows us to examine better. We all know the NBA mechanism. This is JES classification and IPCL classification of esophagus, which allows us to pick up esophageal squamous cell carcinoma at earlier stages. On the left is the white light endoscopy. The middle image shows NBI, which shows B2 and B3 vessels according to JES classification, and the rightmost is the chroma endoscopy with Lugol's iodine, which shows persistent pink sign. Moving on to Barrett's esophagus. This is NBA classification, where irregular mucosal pattern and long elongated corkscrew-like vascular pattern might indicate dysplasia and early cancerous lesion within the Barrett segment. This is chroma endoscopy done with 3% acetic acid. Loss of acetowhitening helps to identify the dysplastic regions, and it guides us to take the biopsy. So we know that the incidence of prevalence of biopsy-proven Barrett's esophagus is low in India, around 2 to 3%. So we should know whom to screen. Any men with chronic GERD, especially with any of the following one risk factor at least: elderly male with central obesity and history of smoking. And also, if they have family history in the first degree of Barrett's esophagus or esophageal adenocarcinoma, then we should consider Barrett's esophagus. So how do we do the surveillance? Apart from what we have seen, white light endoscopy and image enhanced endoscopy, any visible mucosal abnormalities should be biopsied. If there are no mucosal abnormalities, then we should take biopsy according to Seattle biopsy protocol. And nowadays, this VATS 3D biopsy, as we see here, it's a brush biopsy which takes the biopsy in zigzag fashion. It increases the yield rather than taking random biopsies. If the patient has dysplasia and has no dysplasia in the Barrett's segment, then the next endoscopy can be done after 3 to 5 years. If the dysplasia is indefinite, then a course of PPI should be given and then endoscopy should be repeated. If he has low-grade dysplasia, you should consider long-term PPI along with endoscopic surveillance at 6 months, 12 months, and then annually. High-grade dysplasia should be treated. So to sum up the preventive strategies of head and neck and esophageal cancers, quitting smoking is the most pivotal thing, and consider HPV vaccine in age-appropriate people, maintain ideal body weight, and endoscopic surveillance in high-risk group. Moving to the next patient, she is a 45 years female who had a history of dyspepsia on and off since 6 months. And then because of persisting complaints, she came to medical gastro OPD. She also gives history of first degree relative CA stomach. So we advised OGD, and in the OGD, she had antral gastritis and her RUT was positive. Along with that, she had intestinal metaplasia changes in the antrum, for which she took H. pylori treatment. Some of the gastroenterologists might think the treatment part is over here, but not so. I want to tell two take-home points with this case. That is, the first thing is we have to confirm the eradication of H. pylori. If it is not eradicated, then we should go for second and third line regimens and then eradicate it with the if the H. pylori is got eradicated also, still this patient will need continued endoscopic surveillance because of two reasons. She has high risk lesion, that is intestinal metaplasia, and she also has first degree relative with CA stomach. So she should be kept under continued surveillance even after H. pylori eradication. So who needs surveillance? First degree relative with CA stomach and familial adenomatous polyposis, Lynch syndrome, other polyposis syndromes like juvenile polyposis, Peutz-Jeghers, patients with pernicious anemia and adenomatous gastric polyps. Along with the previous mentioned endoscopy requirements specific for gastric cancer, the patient should be given simethicone and N-acetyl preparation before the procedure so that the mucosal visibility will be better. The mucosa will be clean of mucus, debris and the bubbles which is seen during the procedure. And the stomach should be adequately insufflated with CO2, and systematic inspection of the mucosa with freezing of the images should be done. So wherever needed, appropriate mucosal visible abnormality should be biopsied. Along with that, systematic biopsy should be done according to updated Sydney protocol. So H. pylori, we all know it is a well-established class 1 carcinogen. AGA says that HPA eradication is adjunct to both screening and surveillance endoscopy for the prevention of gastric cancer. So they even suggest screening of Helicobacter pylori in the household contacts of patient who tests positive. Though H. pylori, the diagnosis of H. pylori, there are well-established methods like urease breath test and stool antigen, rapid urease test, and in some places serology. There are certain endoscopic findings of gastritis which correlates well with the presence of the infection. A few among them are, first one is the intestinal metaplasia, and the second top one is the diffuse redness, and below we can see enlarged mucosal folds and diffuse nodularity. All these findings strongly suggest the presence of H. pylori in the gastric mucosa. Many studies have confirmed high specificity and sensitivity for these findings. So this is fundic gland polyp, regular arrangements of connecting venules, and hematin and reddish streaks. The presence of these findings should conclude that should give us an idea that H. pylori might be negative for this patient. So there are certain NBA features where the pits are enlarged, elongated with unclear subepithelial capillary networks, or it will be dense and irregular. So with this we can get a clue that the patient has H. pylori. So the top left one is Toronto consensus, which we know well that it says bismuth quadruple regimen or concomitant non-bismuth quadruple regimen should be the first line of management. And the recent one, that ACG guideline, which was published in September 2024 in the era of PCAP, says that vonoprazone based dual therapy can be considered for treatment naive patients, and vonoprazone based triple therapy can be considered for treatment experienced patients. Kyoto classification is for endoscopic, it's done using endoscopic findings. There are 5 findings: atrophy, intestinal metaplasia, enlarged folds, nodularity, and diffuse redness. So if the score is more than or equal to 2, we can consider that Helicobacter pylori infection might be possible. If the score is more than or equal to 4, there is high risk that the patient might develop gastric cancer. This is operative link gastritis assessment classification of atrophy. We should take biopsy according to updated Sydney protocol. That is 2 biopsy from the antrum and 1 from the angulus and 2 from the body, and it should be put in a separate jar. Based on the histopathological examination of this, we can stage the intestinal metaplasia, stage 3 and 4, that is extensive severe intestinal metaplasia is strongly associated with gastric cancer. So to conclude, we should, in any patient who is undergoing endoscopy for dyspepsia or surveillance endoscopy, we should look for atrophy and intestinal metaplasia changes, and if it is present, targeted biopsy and non-targeted biopsy according to Sydney protocol should be done to stage the severity and thus to predict the risk of developing gastric cancer and to decide on when to do the follow-up endoscopy. This is a NBA classification of early gastric cancer based on the mucosal surface pattern and the vascular pattern. So if there is any suspicious lesion, first look for the line of demarcation. If it is present, then look for the mucosal and vascular pattern within the lesion. If it is if the pattern is irregular or there is focal loss of the pattern, then we can suspect gastric cancer. These are all other NBA findings, that is white opaque substance. If it is regular, it can be low grade dysplasia, or if it is irregular, it can indicate high grade dysplasia or early gastric cancer. And white globe appearance is one highly specific finding which is seen in gastric cancers. The light blue crust seen on the right lower down image suggests intestinal metaplasia. To sum up the preventive strategies of gastric cancer, apart from stopping smoking and alcohol consumption, we should eradicate H. pylori infection and endoscopic surveillance in high risk group. The people with high risk intestinal metaplasia phenotypes, incomplete subtype, operative link gastritis stage 3 or 4, and corpus extended intestinal metaplasia, and any patient who persists to have H. pylori infection, that is refractory to all the 3 line of management, and any patients with first degree relative of CA stomach. So all these patients should continue endoscopic surveillance every 3 years once. So the third patient will be 58 years male with no comorbidities. He is not a smoker. He do not take alcohol. He was evaluated elsewhere for, he did not undergo any evaluation. He had dyspepsia and anorexia. He took a mast health checkup himself in some laboratory where they do only blood tests, no other tests. So, which was all normal except for mild transaminitis. Then he consulted a surgeon. He did endoscopy and colonoscopy, which didn't show any significant finding. He was conservatively managed, but then the anorexia persisted. So he came to us for further management. His abdominal examination revealed a palpable liver, and he got diagnosed as hepatitis B related hepatocellular carcinoma. The point from this case is many patients do master health checkup, only blood tests, no X-ray, no ECG, no viral markers, no ultrasound abdomen. The master health checkup criteria should be individualized. It should not be generalized. So who is at risk for hepatocellular carcinoma? anybody who has cirrhosis, which can be of any etiology, chronic hepatitis B and C infection, and recent mast is on rise, which is a cause of HCC, alpha-1 antitrypsin deficiency, aflatoxin, Wilson's, hemochromatosis, and other familial conditions. Alcohol is strongly associated with many GI cancers, including esophageal cancer, pancreatic cancer, colorectal, and hepatocellular carcinoma. Though the high risk group will be anybody who consumes alcohol on very high doses for a chronic period, and any patient who smokes along with alcohol, and patient who is having associated metabolic syndrome. Though this effect of alcohol is duration and dose dependent, there is no safe limit for alcohol, and alcohol screening should be in our daily practice. Hepatitis B screening, we all know this. The point is both HBsAg antigen and anti-HBC total antibody should be done for screening. The management of hepatitis B will be out of scope of this presentation, but EASL says that all HBsAg positive patients with detectable HBDNA levels are candidates of antiviral therapy. Vaccination, ideally all patients who have not received vaccine before, whose vaccine status is unknown, or whose anti-HBs titer is less than 10 should receive the vaccine. Primary non-responders are those who didn't develop adequate antibody response following the primary vaccine series. For the reason might be chronic multiple illness, elderly people, smoking, and obesity. They should be offered a second series of vaccine, preferably with a different brand. Literature says 30 to 50% of these patients who receive second course might develop the antibody response. The antibody retest should be done 1 to 2 months after the last dose of second series. These patients should also be simultaneously evaluated for present or past infection of hepatitis B. Mast cell, there are many factors which commonly associates fatty liver and HCC. It's not just chronic inflammation and oxidative stress, it's multifactorial. The management prevention will be lifestyle changes and pharmacotherapy if we diagnose it early in the steatosis stage or inflammation stage or early fibrosis stage. But once the patient develops cirrhosis, the only prevention aspect will be surveillance for HCC. To sum up the preventive strategies of hepatocellular carcinoma, stop alcohol consumption, get tested for B and C virus, and get treated or vaccinated, whichever is appropriate, maintain ideal body weight, and once advanced fibrosis or cirrhosis has set in, we should follow with 6 monthly ultrasound abdomen and serum alpha fetoprotein. The final case will be a 52 years obese male who is a chronic smoker and alcohol consumption, was evaluated for anemia. He gives history of bleeding, PR on and off. He underwent hemorrhoidectomy, saying that he has hemorrhoids, and followed that he received iron injections and tablets, but he came to us with persisting complaints, bleeding, PR and anemia, and his colonoscopy revealed rectal growth with liver metastasis. The point from this patient, to be taken from this patient, is in the modern gastro era, though many surgeons also do sigmoidoscopy before surgery, we still do get some patients like this where the complete evaluation is missed. So, missed at the initial stages at least. So, the more awareness should be there for the patients also and for some doctors also. So, who is at risk for colorectal cancer? Patients who smoke, patients who consume foods containing high quantity of heme or heterocyclic amines, who do not take much fruits or vegetables, microbial dysbiosis, and familial syndromes. We all know this risk stratification for colorectal cancer. Average risk people should, these are all the various screening tools. Average risk people should receive surveillance of with the sigmoidoscopy every 5 years once, or with colonoscopy every 10 years once, and annual fecal test. Increased risk patients are those with personal history or family history of adenoma or CRC. So this, to simplify, once the number of polyp increases, the size of polyp increases, and it is a sessile serrated polyp, more vigilant the surveillance should be. Personal history of CRC, if the pre-op colonoscopy is complete, then after surgery, 1 year later, we should do follow-up colonoscopy. If it is incomplete, it should be done at an earlier time, 3 to 6 months. Family history, the age at which the surveillance should be started, it should be 40 years or 10 years before the youngest onset of the disease in the family. Good colonoscopy should have adequate bowel preparation, and simethicone based preparations should be given along with the bowel cleansing agents to aid better mucosal visibility that decreases the colon bubbles. Cecal intubation is must, and adequate withdrawal time should be there. This is a nice classification and Kudu's pit pattern for colonic polyps. These are all certain images of colonic polyps where the sessile serrated lesion has indistinct border. It is usually irregular in shape. It has cloud-like surface and it has dark spots within the crypts in NBA. Sessile serrated polyps are easily missed. It needs to be resected wherever it is possible, and the surveillance for these type of polyps should be more vigilant. To sum up the preventive strategies for colorectal cancer: stop alcohol and smoking, limit red meat consumption, avoid processed meat intake, and avoid cooking the food with the char broiling and grilling and frying process, which increases the heteroamine cyclins. So consume more fiber, physical activity, avoid central obesity, and colonoscopic surveillance as indicated, genetic screening for first degree relatives or family, human papilloma virus for anal cancer prevention, and aspirin chemo prevention. This is a study done in our institute where we checked the patient acceptance, feasibility, and diagnostic accuracy of fecal test in the first degree relatives of colorectal cancer. We took 2000 patients. We did both FOBT and FIT. FIT outperformed FOBT, and it is easily available test, and it should be done for all the patient who is at patient relatives who is at high risk. This slide sums up the presentation. Thank you for your listening.
Thank you, Dr. Sujata, for an excellent proposition. Do we take questions now, or Dr. Seshadri, do you have 5 minutes for questions? Dr. Sujata, can you be seated here to take questions? I'll start the questioning. Now, Dr. Sujata, how much do you relate H. pylori to adenocarcinoma of the stomach? We know that the WHO has classified H. pylori as a class 1 carcinogen for carcinoma stomach. Now, H. pylori is 100% related to Malt lymphoma. Now, how convinced are you about H. pylori being a class 1 carcinogen for adenocarcinoma of the stomach?
Sir, exact percentage numbers I don't know, but in the pathway of adenocarcinoma, H. pylori comes early in the pathway where it sets in chronic gastritis, chronic inflammation, due to which the reactive oxygen species, free radicals, and the cellular damage, everything happens.
Let me tell you why I'm asking you this. In Lancet, July 8th, there is an article which says in Southeast Asia, there are people born between 2006 to 2017, there is almost 1 million people are expected to develop carcinoma stomach in Southeast Asia. And they singled out China and India. So now if you're going to expect at the age of say 40 or 50 after 2017, then there is a chance that you could prevent carcinoma stomach and they say identify H. pylori and treat. Now, if population needs to be screening, it has to be by blood tests. It can't be by endoscopy for every single individual. Large scale endoscopy becomes almost impossible. So now, if H. pylori is positive in serology, how important is it? And if you find somebody with H. pylori positivity on serology, would you treat?
Serology is not recommended for H. pylori diagnosis, though some studies suggest IgG antibodies can be done for diagnosis. That does not indicate present infection. So it is not recommended for screening of H. pylori. There are other non-invasive tests like stool H. pylori antigen or breath test, though it is cumbersome, very difficult to do. None of us are doing. So these are all non-invasive options. Though endoscopy is not always needed for diagnosis of H. pylori. Only if the patient is symptomatic, then we are going to do endoscopy, not for just for diagnosing Helicobacter pylori.
I just want to know, if you have, let's say, stool antigen positive, then I think you have a reasonable chance that this patient is having significant
Yes.
symptomatic H. pylori. But if you want to screen millions of people,
Sir, all our cancer prevention modalities, none of them are available for general population, sir. Majority of the preventive measures are available only for at least high risk population. Like that might answer your question. None of our practice is, as he said, only we intervene only when patient develops symptoms. We are still at that stage only.
So actually, in US, we start the colon cancer screening at the age of 45. And family history means a little bit earlier. What I see in Indian patients is we are seeing precancerous large tubular adenomas even in 42, 43-year-old itself now. So same with upper GI cancers. In Japan, Korea, as you know, similar to a screening colonoscopy, they have screening endoscopy.
there the situation is that they go in a van.
Correct.
Here, with 1
So
point.
as you said, sir, I think stool for H. pylori antigen, if we can do it at a mass scale, might not be a bad idea, is what I'm thinking.
You see, I've got a vested interest in asking this question. I'm supposed to deliver a lecture in January in the American College of Gastroenterology on massive health checkup and its relevance to gastroenterology.
Oh.
So since I'm reading, I was wondering what the oncologist would
So
tell.
please say don't check CA 19.9 levels, sir.
So, Dr. Sujata, some of your statements are very provocative and your talk was very interesting. But I think after a very long time, we are seeing a younger person, not a junior person, younger person coming onto stage, and we want to encourage you. You review your slides after 5 years and you see what were provoking and what were probably needs to be corrected. This is my encouraging words to you. And now it is open to everyone. I think from starting with Dr. Paul Manikam, I think I asked a question. How many of you believe diabetes is reversible? And we had only few hands. Can I ask the question again? How many of you believe that diabetes is reversible? Even now, it has become even lesser now. I am a strong believer. I am a strong believer for two reasons. For nearly 20 years, my friend has been sounding this into my ears, and I had my own student from US who does only this reversibility of diabetes. His role is only diet and diabetes, nothing else. No drugs, nothing. He gave counseling for my wife also for 45 minutes and probably 1 hour. That was very early stage actually. Now, if you see the Davidson book, it says 50% of newly diagnosed diabetics can be reversed. This is a real fact actually. Hearing from one Hyderabadi person on a stage, he said, why do you bring in all the waste into the house, garbage into the house, and try to clear it with the drugs? That's exactly what he told. That reflects how you can really reverse it actually. I think there is now a stronger ground, and at least as doctors, we should believe that it's something reversible. You can enlighten on us on this.
Yes, sir. So, it's, of course, it's reversible. But I think what is the missing link? People think it is their diet, right? The missing link was the gut health. The missing element was the 100 trillion gut bacteria. Similar to how many of you know the human genomics study. People evaluated the complete genome. So they did a complete genomic analysis of all this 100 trillion bacteria, and they completed in 2010. And this is available online. You could check it out. we initially thought that I was a part of it as well while I was in the US. We initially thought that that's going to like just break every disease because we can clearly identify which bacteria is causing which. Then we figured out that there is no particular bacteria which is causing a particular disease. All you can figure out is a pattern. So we see the fecal microbiota of diabetes patients, there is a pattern to it in terms of, like which kind of gram-positive bacteria, fungi or gram-negative bacteria is there. It's a pattern. What we figured out is not only in terms of diet, all the 6 pillars that we talked about, if we can maximize and optimize the health, the pattern changes, gut health gets better, gut-brain axis gets better, HPA axis gets better, insulin quality gets better. That is where the diabetes is getting reversed.
Yeah, I think this is what I wanted to start with actually. I'm sad that you had to go through this agony, anxiety, and all this medical illness and all these things.
No, I'm very happy.
I'm also happy that you came out successfully with the opening of a new window, which will be of benefit to millions of people rather than one-to-one relationship.
Correct.
That's what we consider as important. As we grow older and as we become grayer, we always believe in preventive hepatology, preventive gastroenterology. What all can be prevented should be prevented. That's the strength of, as you become older, that's what you want. You don't need to treat. Before treating, what can we do like? That's what we are thinking. It's interesting that I always, wherever I go and talk, I always say, gut is the only gateway to good health. That's what I say always. How many of you agree that gut is the only gateway to good health? Yeah. I think now we have more hands.
The question is for Dr. Palaniappan. Enjoyed your talk. You covered a lot of things, but one of the things I thought you didn't cover, social activities that can be related to stress management as well as gut bacteria and the rest. As you know, Dr. Vivek Murthy, before he was thumped out as general in the Surgeon General, he mentioned this quite a bit. How many families get together supper time? It's totally non-existent. And those are the simple things that can be added on. I wonder whether you have any comments on that.
Of course, sir. So the social connectedness is something that has been talked about as a preventive lifestyle medicine strategy in each and every department. So if you look at the presentation, there was a acronym. It's called MBSR, Mindfulness Based Stress Relaxation Program. Out of this, in that program, what they really highlight is social connectedness, quality over quantity. And if you are a family, spending the dinner time together is something that they are underlining the importance. And they say that oxytocin is being produced, and oxytocin has an indirect effect on cortisol secretion. And as you know, when cortisol is there, no hormones work. The stress is a very, very hidden factor where cortisol is being secreted suboptimally throughout your 24-hour cycle. That is the problem where the circadian rhythm is getting disturbed. I completely agree with you, sir.
I think we are running short of time. So I think I've been advised by the organizers to cut it down now.
Yes, sir.
Thank you. It was both are interesting talks, and I think we should make use of the younger generation speakers, groom them to replace us over a period of around 5 to 10 years. It's very, very important that we have one speaker from the younger generation. The younger people don't think you are junior to anyone. You are younger generation, that's all. Okay, sure. We go on to, thank you, Ramesh. We go on to the next thing. Gastro talk is, I think it's going to be extremely interesting, and he's going to create a lot of laughter, and I think he will tickle you every side, and we will see how it goes. Sure.
So
over to Dr. Shetty.
yeah, thank you, sir. So this is going to be offbeat. Some science, some movies, everything together, food, everything. And with Dr. Pal here, there should be some of gut and gut bacteria, bacteria, everything. So we'll start off. I thought since there's going to be the last TNSG meeting for the year, we should finish it in a very light way. And so all of you are awake now. So let's start with that.
Roll camera action.
Started the movie now. So there'll be next few minutes. We'll have some questions. These questions will be based on little about movie, GI Connect, and then some basic day-to-day things. So there'll be some discussion after the questions, and there are prizes for the answers. I actually asked them to get 10 pens so that there will be gifts for the answers. But I thought there will be only 10 people. Luckily, there are more people. 1:1 kadachirukkum illati. So the jury will be a part of the panel will also be a part of the jury. So if there's any doubt in the answers, you can come in. And of course, most important thing, no question to the quizzer. Right. First question. What are these? What are these seen over here? This is for the postgraduates. What are these and what are they used for? Okay, I'll give you a clue now. I can probably go with the clue.
Acidity.
Correct. Who said that? So what are these? You're partly correct. Yeah, they are brown algae. These are the source for alginates. So, thank you. So I think the prize is over for you, unless there is no one else who is answering the question. Okay, so we'll go to the next one. It's going to be a video. I think this is for maybe the younger generation may not know. There's no prize for this, but you can just listen to the song and then, oh my God.
நின்றவனே அந்த சாட்சிய சொல்ல வந்தவனே அதே அதே சபாபதே அதே அதே சபாபதே தம்புலிங்கமே ஜடாதரா ஜோதிலிங்கமே ஹரோகரா ஹரஹர சிவ சிவ ஹரோகரா ஹரஹர சிவ சிவ ஹரோகரா ஹரஹர சிவ சிவ ஹரோகரா ஹரஹர சிவ சிவ ஹரோகரா.
So it's a very famous movie at that around 50s and 60s. So any guess for what is the movie? அப்பா கிரண் எங்கேயோ போயிட்ட நீ பார்த்துட்டியா அதை? Okay, the movie was காசேதான் கடவுளடா. But for us, gaseதான் கடவுளடா. Because our survival is based on patient coming with gas problems, right? So now just see the video and tell what is being prepared and what are the benefits of that. Who told the first answer? Payasur, who said? Okay. Right, so Payasur is being done, and what are the health benefits for that? What are the health benefits? Probiotics, then? A bit good. Probiotics, then? You can give us, sir. Oh, அப்படியா? இன்னும் டெஃபினட்டாக கொடுக்கலாம். Right, so it's a பழைய சாதம், பழஞ்சோறு. It's rich in nutrients and probiotics and supposed to help in absorption of iron and calcium. In fact, the water is also equally. In fact, the water is also equally nutritious. All of us in our childhood, I think we've had. Bharat, you had Birama. Sir, KRP, sir. இப்போ எடுத்துப்பீங்கன்னு நினைக்கிறேங்க வில்லேஜ் போனா பழஞ்சோறு பழைய சோறு. What about you, sir? I think every day. Yeah, fantastic. My father used to have it every day in the morning. When we used to go to Tirunelveli, we had it there. At home also we had it. It's really good. I think when that is being adopted by the hotels also, I think. The old food is being recirculated. So it's Payasur is there also. Right, after Payasur, we'll come to the next thing, which is the passion for most of us. Yes, sir.
In the breakfast menu in this hotel, Palay Sur is one of the component here.
Component, yeah.
பரோட்டா சாப்பிட்றது சில ரூல்ஸ் இருக்கு.
முதல்ல கறி போட்டுக்கோ. எட்டு பக்கத்தில் வை. இப்போ குழம்பு போட்டு இப்படி எட்டு வாயில் போட்டுக்கோ. கண்ண மூடி. இப்போ சொல்லு எப்படின்னு. அடி போடு. அடி போடு.
How many parota fans here? So how all will you eat parota? I'll tell how I eat. Parota vechipem plate la. Pour all the kurma on that. Allow it to soak well. Then have it happily. So what about... hey, mic circulate பண்ணுங்கப்பா. Bharat?
With mutton or mutton predominantly.
Mutton. Anyone else who wants to say about their parota? Kottu parota, other types? Sir, I've heard your vlogs about parota and people asking you questions about parota. I think you should say something.
ஸோ மதுரையில் வந்து பன் பரோட்டான்னு ஒன்று இருக்குது, பார்த்துருக்கீங்களா?
சாப்பிட்ருக்கோம் நாங்கள். பரத் நம்மளாம் போய் சாப்பிட்டோம்.
நான் வந்து அந்த கடைக்கு போய் வந்து வெயிங் மிஷின் எடுத்துகிட்டு போய் அதை வந்து மெஷர் பண்ணேன். அந்த அவன் நினச்சிட்டான் நான் யூடியூபர், அதனால வந்து ஃபுட்டை ரிவ்யூ பண்ணுறதுக்காக வந்திருக்கேன் அப்படின்ட்டு. அவன் யூடியூப் பார்த்ததுக்கப்புறம் என்ன கேட்குறான், ஆடா பாவி நீ இதுக்கு தான் வந்தியாடா.
Right, so we'll proceed. So again, it's a small video.
श्वास छोड़ें, जांघों और घुटनों को छाती के निकट लाएं। श्वास लें और दोनों हाथों की उंगलियों को आपस में जकड़ते हुए दोनों पैरों की पिंडलियों को कसकर पकड़ लें। श्वास छोड़ें, सिर तथा कंधे उठाएं और ठोड़ी को घुटनों के बीच लगाने का प्रयास करें। इस स्थिति में 3 से 5 श्वासों तक बने रहें।
What asana is this? Wild guesses? Slight change in the words. You can take the clue from her. Slight change in the words. Letters you put here and there, you'll get that asana. We are talking about gas. Gattasana. Pudu asana. Kandupidikalam namba. Right, so no one gets it. So it is called Pavana Muktasana. It is supposed to help in releasing gas. So you can tell your patients next time to do this unless they have back problem. So we go to the next one. Right, go through this video and tell what GI phenomenon this video strip describes.
டச் பண்ணுவேன். போடா. என்னங்க? எக்ஸ்கியூஸ் மீ, இவர் என்னன்னு கேளுங்க. என்ன சார்? போடா பண்ணி. என்னடா சொன்ன? போடா பண்ணி. என்னன்னு கேட்டா போடா பண்ணிங்கறியா? பெரிய ஒரு மரியாதைக்காக பாக்குறேன். இல்லனா பீஸ் பீஸ் ஆகிடுவேன் பீச் மாங்கா பாரு. ராஸ்கல். ஏய், சிரிக்கிறா நீ? எல்லாருக்கும் இடுப்புல குத்தா கிச்சு கிச்சு வந்து கக்க கக்கன்னு சிரிப்பாங்க. ஆனா கடவுள் எனக்கு மட்டும் இப்படி ஒரு வீக்னஸ் கொடுத்திருக்கான். அத வச்சு நீ அடி வாங்கிறியா? உன் பொண்ணு சத்தியமா கட்ட மாட்டேன்டா. இது எங்க ஆத்தா பூமணத்தை பிச்சாத்தாமல சத்தியம். டேய், கைய நீட்ட போமா ஊறி தள்ளிடுவேன். போயிரு. போடாங்கறே டுபுக்கு.
Just keep in your mind when you come to it.
போடா.
மிஸ்டர் பலவேஷம், வந்திருந்த கிளையண்ட் ஒருத்தர போடா பண்ணின்னு திட்டினீங்களாமே.
I have one spot in my what is English for இடுப்பு மேடம்? Hip. Somebody cutting, I am cutting. என்ன மேல விளையாடிட்டு?
ஒழுங்கா விளக்கம் சொல்லனா உங்களை வேலைய விட்டு நீக்கிடுவேன்.
போடா பண்ணி.
What? You are telling me?
போடா. சொட்ட தலையா.
Idiot. போன் அவே மேன்.
சாயந்தரம் வந்து சம்பளம் வாங்கி வாங்கிட்டு போ. சார். இப்போவாது சொல்லு. என் பொண்ணு 5 கிட்ட கட்டிக்கிறே.
So, pardon? Gut brain axis, not exactly. A little closer. So, you want a clue? That's pathogenesis in IBS. Visceral hypersensitivity. Exactly. So, that is the stimulus, and he's got an abnormal, so many inciting factors, and he has got a very abnormal hypersensitive response, and he's suffering from that. And this hypersensitive response could be having some genetic background also. Bharat? Well, who else told? Among the PGs, anyone told? இல்லையா, யாருக்கும் பேனா வேணாமா? சரி, ஓகே, ரைட். ஸோ வில் கோ டு த நெக்ஸ்ட் ஒன். ஓகே, Who is this and what are her achievements? Wait. Fantastic. What's her name? Mithila must be your girlfriend. What's her name? Maithili Thakur. Okay. She is the youngest MLA at 25 years of age. I think you got one, no? Aye. Who else answered? Illiya. Ella pennu waste ஆகும் போல இருக்கே. So she is the youngest MLA who won recently from Bihar, and she is one from the Alinagar constituency with almost 11,000 votes, and she is a classical singer. She's got good name in Madhubani art and other things also. Right. Now find out this condition with the clues given.
வரணுமா வரும் ஆனா வராது வரும் ஆனா வராது வரும் சொல்லு இல்ல வராது சொல்லு ஏன் இப்படி போட்டு குழப்புற வரும் தம்பி ஆனா வராது என்னடா ஓவரா இழுக்கிறான் இந்த மாதிரியா
Constipation. Refine it further. Not just constipation. Who said dyssynergic defecation? Yeah, please. So it's dyssynergic defecation. It's not just constipation. Adla varum ana varadu. Adan dyssynergy exactly. Yeah, sure. So I think studying is becoming more interesting now. Right. I think Dr. Pal should try to get this. This I got it recently from a newspaper clipping. So seeing this, are you able to find out what it's trying to depict? I think it's a little difficult. DNA. What is it? What have they made the DNA out of? Fiber. Food items. Food items and fiber and everything. Who said that? Okay, come. It's about, it's called nutrigenomics. I think food genomics can be given. What's your name, doctor? Sanjeev, very good. So it is all about food-gene interaction and gene-food interaction. It's not just we eat, and it's something which I got to learn a lot in the newspaper recently. Like whatever we eat, it redesigns our genetic system, the way things are being digested, and to the extent that even the digestion and absorption in the future generations also can change. So what we eat today will dictate how our next generations are. So that's the important, that's why you should not junk too much, right, sir? Okay, identify this. Dubai? Dubai Sheikh. Yeah, it's a golden toilet, but I need more specifics. What is it? What is the weight and what is its name? It's got a very unique name. If anyone can guess it. Okay, I'll give it to sir for golden toilet. Right. So it's got very interesting facts. It's a toilet seat made up of 18 karat gold. And it was designed by Maurizio Catalan. It's an Italian artist who has got a lot of other crazy arts also. I'll just show it to that. It was in 2016. You guess the name. Take a wild guess what the name could be. And it's open to the crowd. Take a wild guess. Okay. Let's see what all names comes. Gold shit. Then, hey, postgraduates, come on, man. Let your mind go wild. But I don't think you'll get the correct answer. Anybody? Sir? Bharat, Pirama? Sir, care, sir, any? Right. You'll be surprised if I tell the name. It was named America by the Italian. I think the guy was really angry with. So actually, the toilet seat is around 101 kgs, and it was auctioned for 12.1 millions at Tnisg. It was brought by Ripley's, believe it or not. So the tagline can go, and it was kept in Britain. It was stolen from Britain, actually, and then they got it again, and then it was sold. So now the tagline can go like this, no? America stolen from Britain in 2019 and auctioned for 1.2 million in 2025. So, and you can keep telling so many things, no? I don't know how the people are used to shit that at all. I can sit on that, etc. So the same person is got weird arts. He has once put up an art with just a banana on the wall, put a staple on that, and they've called it as a huge art, which has, and he's given it his name as comedian. And imagine how much this has been sold for. It's almost, that's the huge amount for it, just a banana. And a tape on that has been sold. He's given some specifications. It should be at 1.6 meters from the floor and other things. So, with a simple banana, he was able to earn such a large amount, right? The ஒரு வாழை பழத்தை வச்சு இவ்வளோ பண்ணிருக்காங்க. But we know how much banana has given us. No, this has bought more money than anything else. I think this one, no, how much ever we see again and again, we can laugh at it. And we use it so many times in our day-to-day life and whatever we see. So let's enjoy it for a few minutes.
என்னது பழம்? நான் உங்ககிட்ட எத்தனை வாங்கிட்டு சொன்னேன்? 2. ஒன்னு இருக்கு, இன்னொன்னு எங்க? இன்னொன்னு தாங்க இது. டேய், நான் உங்ககிட்ட என்ன சொன்னேன்? பழம் வாங்கிட்டு வர சொன்னீங்க. எவ்வளவு கொடுத்த? 1 ரூபா. 1 ரூபாய்க்கு எத்தனை பழம்? 2 பழம். ஒன்னு இந்த இருக்கு, இன்னொன்னு எங்க? இன்னொன்னு தாங்க இது. ஏய், நான் உங்ககிட்ட என்ன சொன்னேன்? பழம் வாங்கி சொன்னீங்க. எத்தனை பழம்? 2 பழம். நான் உங்ககிட்ட எவ்வளவு கொடுத்தேன்? 1 ரூபா. 1 ரூபாய்க்கு எத்தனை பழம்? 2 பழம். ஒன்னு இந்த இருக்கு, இன்னொன்னு எங்க? இன்னொன்னு தாங்க இது. என்ன அவன்கிட்ட போய் சண்டை போட்டுக்கிட்டு? அவன் நம்ம செட்டு. என்ன நம்ம செட்டு? பெரிய சேவிங் செட்டு. அவன் என்ன செஞ்சிருக்கா? என்ன செஞ்சா?
So during a short of time we'll go. I think this is worth more than the amount which was paid for the banana art. You can go on and on like this for this. Right. So this picture I took today. Quickly identify whatever plant or tree this is. Yeah. So the unusual thing about this is it's an unseasonal mango. Who answered this? I'm not giving the prices at all. Sir. Right. So what does this indicate? I was literally worried. I wasn't sure whether I should be happy that the mangoes are coming at the rainy season. You don't see the mangoes in the rainy season at all. This is in my house actually. I'm picking up the mangoes, but I see a lot of flowering even more today. So should I be happy or should I be worried? I think it's a sign of climate change, right? So I think we should be worried because it's giving a lot of problem with our food security. And I think indirectly climate change and the food security is going to affect our gut bacteria. And I think, anything, sir, you want to say?
So there is a society called Indian Society of Lifestyle Medicine. People who don't know, you need to look it up. I think you should become a member of it, and you have to take an exam. I was recently in a conference in Ahmedabad. They talked about this and affecting the gut bacteria, and also the microplastics. Which is slowly seeping into. For example, all these are slowly getting accumulated. So these two things they're really focused upon. I think for gastroenterologists, everybody, you should look at ISLM, Indian Society of Lifestyle Medicine.
I think microplastics is a big thing. I think I wanted to include that, but I just think there's no time. So I think we need to be nature responsible, no? Because the earth is not only for us, for our future generations, we have to be more responsible for children and have to survive.
अरे क्या सुबह सुबह फोन कर रहा है? कोई मर गया है क्या?
So just keep looking at that.
बॉस आप जिंदा हो? थैंक यू ब्रदर. अच्छा हुआ तूने कुछ नहीं किया.
वेलकम. कभी कुछ ना करके भी देखो. Eat 5 star. Do nothing.
So doing nothing, no? It's an art nowadays. No? We used to just relax and just sit and just do nothing. Just stretch our legs in front of the rain, see the rain, do nothing. But nowadays it's becoming that our children are not just able to do nothing. They have to do something with the phone or something, no? So do you know what is that called? The art of doing nothing. There's a Dutch word for that. Not heard of that? It's called Nixon. It's something coming up in a big way because there's a lot of burnout at work. So just doing nothing is becoming a very important thing. So, but the actual question is, which are conditions in GI? We just want to just wait and watch. No intervention will help. Just want to wait and watch for the disease to. Okay. Something in pancreas, that was the answer I was expecting. I confirmed with Pirama also. Then only I put this question. What sort of fluid collection? No? Okay. Who said? Right. I can give it for someone who said asymptomatic pseudocyst. And other answers are also, I can say, sometimes gastroenteritis. Hepatitis B, I think it's controversial now. So I think we have to. So just doing nothing is also a very nice thing now. Okay. Identify this now. Who gets this? Fantastic. Who said that? Right. Get it. So I think you should be I think these people have done really well. Are blind. So who else? Anyone else told blind women's cricket cup winners, India? Right. So I think they've done a wonderful job. They've won all the preliminary matches and they won the cup also. So it's a big clap to our blind women. Women have done really well this time. The World Cup they won and other things also. Right. Other general knowledge question. These things you will know if you have read the papers recently. So identify this. No, not Ahmedabad. No. Who said? Huh? Yeah. It's an Air India Airbus only. But what is that? Someone? Exactly. Perfectly. You got it bang on right. Yeah. So it's actually a forgotten plane. We don't know how exactly they forgot the plane. What's your name, doctor? Good. You read the newspapers very well, I think. So it's a forgotten plane. I don't know how someone can forget a plane. So it was suddenly found that in Calcutta a plane was parked for such a long time and they wanted to find a space and they searched and found that this plane is lying down for a long time. And Air India thought they lost the aircraft. It was not there in their list of flights also. So it was then they finally dug up and saw that it was in 1982, it was with Indian Airlines and then it came to Air India. It was grounded in 2012 to 2015, 25, happily sleeping in Kolkata. And then suddenly someone realized, and when they asked the Air India people, they said that they didn't even know existed. So it is up for sale. If anyone is interested, they can go and buy. I think KRP sir, biddings. Trainer aircraft. They are selling to someone to use it as a trainer aircraft. Air India is using. Sorry sir, gone. Right. So what the question for this is common forgotten things in GI practice. No. What I'm saying is some objects that are forgotten. Objects which are placed inside the patient that are forgotten. Stents. So do you take this? Who else among the postgraduates told stents? Yeah. Right. So forgotten biliary and pancreatic stents are very common actually. No, it's a big trouble. So a patient just come back. Can you know those who've done the longest forgotten stents? Have you come across? What is the longest you've seen? 5 years, 6 years, 7 years. Someone said 7 years. 7 years. It will come out in pieces only. I think. No, it's very difficult to take it after that. Anand, பேசவே மாட்டேங்கிற Pirama, Bharat? Nothing, okay. Right, so it's very important to tell all the patients that the stents have to be removed. No, at least the easiest way is to document in the report that the stent has to be removed or exchanged within 3 months. Right. So I think we are coming to the end of the session. I think you all enjoyed it. So this used to be the song in every in Doordarshan, no? Every New Year, this used to be a standard song, and still the song is nice to listen in here. So thank you for the patient hearing, and have a nice dinner. So, and have a nice year ahead. They can eat everything, sir.
Yeah.
Thank you very much.
Dr.
After over to Arul Prakash.
Dear friends and colleagues, we had a wonderful evening today. Mixture of knowledge and fun. And I would like to thank all the speakers from the postgraduates who being a part of the panel. And it was a wonderful presentation from Anusha and CME on preventive gastroenterology is a new one, and thanks Dr. Palaniappan and Dr. Sujata to enlighten upon preventive strategies in gastroenterology. And so we'll be meeting in the February again, because we have meetings next consecutive 2 months. I would like to invite Dr. K.R. Palaniswamy, our patron, to felicitate our guest a speaker who has been here for the first time, Dr. Palaniappan. Thank you, Dr. Palaniappan. Thanks for the insight and making us understand what we should do to make the future brighter for us and for the next generation. Thank you so much. So I'd like to thank all the participants. In spite of having a rainy day and a cyclone approaching, you all made an attempt to attend. And thanks the chairpersons, panelists, and the speakers. And thanks Residency Tower to provide this ambience, and Zydus for giving us this opportunity to have this CME here. So with this, we'll wind up this session and we'll meet in February meeting again. Now we can proceed to dinner, please. Thank you. Thank you all. Happy New Year to everyone. Thank you.